stakeholders, international and national organizations in Cambodia. The procedure that created based on the consensus and the best way that we synthesize from all possible options with the stakeholders, it became the standard for use to identify the poor household in the country. That's one thing. It became the standard for identify. That standard has two criteria. One is quantitative, another is qualitative. So two components in that. We use that to identify the poor. Another one is that the practice of using standard is written as a legal mandate for all people working to identify the poor. They have to follow the procedure. It's sort of by law that you have to do it. Otherwise, we cannot assure the standardization of the ID pool at all. It means that everyone implemented strictly according to the procedures created. So it becomes obvious everywhere throughout the country. Not only that, ID pool also responsive to the need of stakeholders or intervention ministries. We not only stay fixed with what we have done, but we updated what the other needed in order to provide intervention. Example for that is that we creating the ODID, which is ID pool on demand. ID pool is implemented every 3 years in each village throughout Cambodia. Within that period, we missed or something happened to poor household because 3 years is a long period. Anything can happen. So we create ODID to meet the demand for intervention or service providers so that they can capture people who in need for their service within that period faster. There are other points that I would love to do, but time is running out. Another one is the decree of the government released in 2011 that every intervention program should use ID pool data for their intervention. So it's a legal framework that everyone has to use it. And now we have National Social Protection Policy Framework that just recently launched, will be based on ID pool data, totally is based on ID pool data. Thank you.
Thank you very much, Minister. I think that's very important to emphasize the key role that you play as a more neutral governmental body that's not in charge of not as any one sector that's in charge of implementation, and the crucial role that you play in setting planning and coordination at a much higher level, as well as the key importance of legislation, of creating very clear legal mandates and very clear protocols that other sectors, across sectors, can follow. Thank you very much for sharing your experience. We will now move from Asia to Sub-Saharan Africa, and we're going to come to South Africa and then Malawi. In South Africa, we're very honored to have the experience that Dr. Simonela had in 2016, the role you played as special advisor to the Vice President of South Africa, where you played a leadership role in the design of the She Conquers campaign, yet another example in the BMJ supplement. While there was ambition started with reducing the burden of HIV among young women, it was clear that for young women to reach their full potential and power, they needed services beyond the health sector and needed coordination and linkages with education, social protection, and other sectors. This was also the basis of the life course approach that you're leading as Assistant Director General at WHO. Would you be able to talk to us about why you think a life course approach is absolutely fundamental and how multisectoral action was a key part in defining the campaign? And what enabled you to bring all these different stakeholders around the table to take ownership of this agenda?
Thank you. Thank you very much. I'll start with just highlights of how we designed and looked at the challenges of HIV infections among young women and girls in South Africa. Many of the people here know that South Africa is battling a very high burden of HIV and TB. In 2016, we were confronted by the reality of 2,000 new HIV infections a week amongst the 15 to 24-year-olds. This was declared a national crisis because we were aware of the fact that if this group of the population was exposed to HIV at these rates, we were going to have a huge challenge as they grow older and go into childbearing age. So what did we do? I think what we did is we pulled in the expertise of our researchers and social scientists who helped us map where the epidemic was happening and how the transmission networks were happening. That, I think, was the key, because through that research, we understood who is infecting who and where are the young girls picking up this infection. Following that, we picked up 22 high priority districts so that we could focus the program and not try and do anything and everything for everybody. After that, we then tried to understand what were the risk factors that were making these young girls vulnerable. It was clear that first and foremost, young girls are not ill, even though they were infected with HIV. They don't naturally come into the clinics. They needed much more than condoms or treatment of STIs and things like that. They needed to get into school. They needed social support. They needed transport to get to school. They needed an environment that didn't have gender-based violence. They needed proper housing and things like that. Luckily, through the leadership of the now president of the country, he leads the AIDS Council of South Africa, which consists of all the ministers, education, social development, and others, including all the sectors, men's sector, women, faith, everybody is around the table. So this was then proclaimed in Parliament as an all-of-government, all-of-society campaign. The young girls were front and center in designing the campaign, giving it a name, which I think was quite powerful. She conquers HIV, conquers poverty, conquers violence, etc. They are running with the program now, and all of the sectors that I've mentioned are contributing and continuing to work to secure the future of these young girls. This is the basis for many other studies that have been done that I found in WHO was also the concept that was starting to gain traction, this life course approach, because it became very clear from the many studies and using this She Conquers as an example that the investments that you make in pregnancy and early childhood are so critical. In South Africa, we managed to reduce mother-to-child transmission from 39% to less than 1%, but that same cohort then became infected when they became adolescents. So it really was very important for the sectors to work together, almost for like the obstetricians, you look after the pregnant women, ensure that babies are not infected, but then you hand over to the pediatricians who must sustain the well-being of those children. When they go into ECD, you must then ensure that they've got all the support, the nurturing care framework, the nutrition, the environment that makes them thrive. And then when they become adolescents, you bring across programs like these. So you have a continuum that ensures that whatever investments are made in early childhood, they are sustained throughout. Therefore, you end up with well women, well men, who become good contributors to your socio-economic development, who then age and become strong and healthy aging adults. So that is the concept that is being driven and that we're hoping all member states will adopt as we move forward to attain the SDGs. Thank you.
Thank you, Dr. Similela. And I think earlier in the first plenary, there was a wide range acceptance and affirmation of the importance of sexual and reproductive rights. And I think the She Conquers campaign, with your vision, really broadens that we need to look at the response, not just in terms of providing services, but taking a life course approach, but really looks at all the social determinants that make young girls vulnerable to HIV in South Africa. Thanks very much for your contributions. We're going to move to Dr. Kachale from Malawi. I know at the same time, this is like multisectoral action in real life. There are many competing priorities, and it's part of the challenge of keeping people engaged while they're juggling many other responsibilities. So the minister from Cambodia had to go back to the ministerial conclave, and I expect that Dr. Similela and Dr. Kachale will also, after their interventions, head to the ministerial conclave that's happening right now. But before we do so, let me give an opportunity to Fannie Kachale from the Ministry of Health. You're a key champion of the Chipatala Chapafoni Health Center by Phone, otherwise known as CCPF. It provides individual health and nutrition information through a toll-free hotline in Malawi. And it's an interesting example of how a local innovation can be scaled up nationally and transition then and be owned by the government. Could you tell us a little bit of what was behind the scale-up and who were the different sectors that were brought together in that scale-up?
Thank you very much, Chairperson. Ladies and gentlemen, thank you for allowing me to join you and share this reflection from Malawi. And I'm especially honored to be back in India, a country that inspires me with its ability to solve complex health challenges. So the Chipatala Chapafoni, as she has rightly said, is health center by phone, literally translated, which was a hotline. It began as an idea in 2011 by Malawian community member for Malawian community members. And it was initially for maternal and newborn health, including nutrition, but later on we have scaled up to all elements in the country. The situation in Malawi is such that about 83% of the population are in the rural area, and still many communities whose local health center is simply too far away actually rely on this CCPF. I'll be calling it CCPF, the health center by phone. So it was meant to give them information, but not to replace the health center, but just supplement with information that they would need. And we started in 2011, like I said, in one district in the southern region, and we actually had some people who were manning the hotline, so people would be able to phone in and ask questions on maternal and newborn health, and the people who were at the hotline would give responses. So they would either be told to say, you can actually go to the health center tomorrow, or they would be given answers because we were actually supplying them with information. Scale up did not happen in a linear fashion. We started with one district, moved to 8 more, but as I'm talking, the country has got 29 districts, 28, one is divided administratively, so we are now into all the 29 districts. An independent evaluation of the CCPF was equally done, and it actually showed improvements in terms of knowledge about maternal and child health and certain health behaviors that were actually changing. As we moved along, some more partners joined. With the CCPF, we did it with an NGO called Village Reach. But as people saw the benefits, the US government joined in, and it worked through the PEPFAR Dreams project, where they actually increased to more districts that they were actually supporting. GIZ also got motivated, and they added the nutrition part to the hotline. Then Airtel began the zero rating of the cost of incoming calls. Airtel is the mobile company that was actually supporting, and actually it's an Indian-based company. And then our own government provided the space at the health promotion unit. From 2016, that's when we started the transition, where Village Reach actually seconded a person who worked with the Ministry of Health so that transition could take place. And we now moved even all the equipment for hotline to the health promotion unit in Lilongwe. So we moved from Balaka to Lilongwe, where we are now covering all the districts. Initially, it started with just the Reproductive Health Directorate, where I am leading, but later on, we spread to the other directorates, the Planning Directorate, as well as the clinical services, now that we are covering more ailments. Otherwise, I think it worked because we all shared a common vision, and Village Reach actually was a strong partner who worked with us as a ministry, and Village Reach also made sure that it signed a memorandum of understanding with Airtel company, which the Ministry of Health now from 2019 has to take over and sign that memorandum of understanding. I think generally that's what I can tell about CCPF.
Thank you very much. Thank you very much for sharing the lessons of scaling up, working with NGOs, but also with technology partners in bringing that innovation and bringing and enabling a voice for communities to share information on health and nutrition. I'd like to give another warm round of applause for Dr. Simulela and Ms. Fannie Kachale. They might have to step out and join the ministerial conclave. So thank you so much for taking time away from the ministerial conclave and joining us. There'll be much more opportunity to answer questions on the case studies in the concurrent sessions that will ensue shortly. So now we have a rapid fire session where we have some leading experts who have real life experience. Dr. Maureen Samms-Vaughan leading the first commission on ECD in Jamaica, Dr. Purnima Menon working extensively on nutrition, bringing sectors together, and our colleague, Dr. David Jacome, working at a physician, at a community level, seeing the need for multisectoral action. So let me hand over to Maureen. Over the many years of experience that you've had, what do you think are the essential features in sparking political will for multisectoral action and sustaining it?
Thank you, Asha. Okay, so this is a speed about ECD in Jamaica. ECD in Jamaica was first driven by a stakeholder response. Stakeholders became concerned about the lack of comprehensive services and the lack of coordination of the services. So they then met with the government to say, what's going on with ECD? We want better for ECD. That passion led to the contact with the government. The government then responded by saying, let's have a look at this and let's look at it properly. So the next step was to get accurate data from the concerns of the people. So the next step was to do a situation analysis on ECD and then formulate a response based on that analysis. The government of Jamaica's response was to establish a new organization, the Early Childhood Commission, which was designed for the purpose of coordination. There were important steps that were taken. The first was to establish the organization in legislation and policy. That was the first step. 2 was to make sure that the organization was sustainable. By making sure it was a government agency, it was then fully funded. The third step was to make sure that there was good leadership to drive the multisectoral approach. The structure, that leadership, then was able to ensure that the structure met the needs for the original development of the organization. Then there was a process of learning, and we did have to learn. When we started the cross-sectoral approach in Jamaica, we were building the bicycle as we were riding it. There was not a lot of information around about how to work cross-sectorally, and so we had to learn, make mistakes, learn again, and keep on going. What were key things that were important? One was communication, very good soft skills, communication and interpersonal skills, and an honest, non-judgmental understanding of the strengths and challenges of sector partners. We had to adjust along the way. So when we had an epidemic, when we had a hurricane, the Ministry of Health couldn't meet their targets. And we had to understand that, and we had to adjust. But separate and apart from having those soft skills, you also have to work together to identify and clearly define the role of each partner for each goal. So after you do the soft, fuzzy bits, which is the interpersonal bits, the communication bits, the working together to work things out, and we had to identify the strengths, right? So the health sector has the greatest access between 0 to 3 because our immunization rates are high. The education sector has the greatest access between 3 and 6 because 95% of our kids are in preschool by 3. So we worked out what the health sector's role was, what the education sector's role was. But after that, then you had to get to the hard facts. You had to document things, and you had to document who was going to do what. And then after you documented that, you had to get that signed and bought into at the highest level. So we had MOUs by all our sector partners signed at the level of the permanent secretary in each agency. And then we had the review and revise process. We found that this worked very well. Thank you.
Thank you, Maureen. I think you've succinctly summarized many key lessons, and you have a lot more to share. So I hope people will take the opportunity to talk to you as well as your colleagues from Jamaica leading this. Let me hand over to Purnima. There are a lot of common themes here: community demand, data, learning, coordination. What are some key insights from your work in nutrition?
Thank you, Asha. It's an absolute pleasure to be with you all today. And I'm so pleased to have heard nutrition so many times today as well. So I think we've infiltrated this sector really well. So nutrition has a really long history of trying to work across sectors, and that's because our sector or our area of work has never had a ministry. We've always been units within the Ministry of Health or with ministries of agriculture. And the problems that nutrition tries to tackle are affected by so many different determinants that there's almost been no choice but to try and work with different sectors. So the initial plans to try and work across sectors, I believe, started in the 1970s. And then after the 1992 International Congress on Nutrition, several countries made these elaborate multi-sectoral plans, and not much happened after that. So I think our sector has spent a lot of time trying to think about what worked then, what didn't work then, and we're in a much better place now because there's been a lot of investment in learning, and some of the things that Maureen spoke about really resonate with what the nutrition sector has been doing. So we've learned a few things, and I just want to summarize those quickly. Firstly, we do multi-sectoral work because the drivers of the problem that we are trying to tackle lie in many sectors, right? So what that requires us to think about is deep clarity on what exactly is the ask of every sector. So we are now able to say we want agriculture to deliver adequate food to nourish the world, not just to remove hunger. and to reduce the amount of unhealthy food. We know we want the social protection sector to address poverty. So we've been able to get to clarity. We've built a lot of evidence along the way of multisectoral efforts to address nutrition and have learned about the routes to impact of different sectors, and we're now trying to pull it together. We've learned that we have to get to what's in it for you. The health sector must care about nutrition because nutrition underlies 45% of the child deaths that you all in this room are trying to prevent. The sectors that work on strengthening the economy or reducing poverty know they need to address nutrition because it drives the economy, among other things. So we've tried to do and bring together the evidence around that. The other thing we've learned is very similar to what Maureen said, which is that no single sector can be a convening sector for nutrition. It must lie outside a core sector. That's absolutely critical to success. No country has done this with multisectoral actions for nutrition being led from within a ministry, because no single ministry can convene another ministry. So we say plan sectorally, plan multisectorally, implement sectorally, and review cross-sectorally. We're also now starting to talk a lot about co-location as an efficient strategy to work together. So identify geographic areas where you need to target all of these different determinants and just work across and then review together. But don't get lost in the process, because the multi-sectoral collaborative discussion processes can sometimes lead, you forget what your goal is. So you need to be very focused in those discussions to bring clarity. So it really, to me, boils down to clarity of purpose, plan together, review together, but do run as fast as you can from wherever you are to tackle the drivers of malnutrition that are in your hands. So those are some of the things that our sector has learned.
Thank you so much, Purnima, for sharing the rich experiences from nutrition and echoing some of the key messages on defining roles, thinking strategically, and combining the soft skills that Maureen mentioned, but with hard accountability of what we're trying to define for each sector and monitoring that over time. David, what would you like to say and share from listening to the panel, as well as from your experiences as a physician working at the community level on multisectoral action?
Thank you very much, Asha. So I wanted to share very briefly my story. I finished med school last year, and I took a year off where I was involved in the NGO level, so I was able to attend different conferences and learn a lot about SDGs, Every Woman, Every Child, global goals, and as many acronyms as you would like to think. And then I was given the opportunity and the challenge to start working on a community in the Amazon of Ecuador. And I was ready to implement all these acronyms and all these ideas and all these goals into the community. And then I faced a huge barrier, that is that the community doesn't know that. Doesn't know them, they don't know what the SDG is, they know what global goal is. And I was given the challenge to do it, and I'm still on that challenge because I'm still working there. So it's very sad that what I'm going to say, but I'm supposed to give contraception to people, to a community where women are not more than mothers. I'm supposed to give vaccines to children that some of them don't even have names, and they are like 6 months old. And I'm supposed also to give health in general to people who are not empowered enough in their health. So it's a very, very, very frustrating situation for me sometimes, because I'm giving a lot of opportunities to hear about the success stories, about the case studies, and I wish them that I would be able to apply them in my context. So how it is related to multisectoral collaboration? I think that now more than ever, I am fully aware of what I need to do is that to start working with different actors of the community. Start working from the community to the top. Why? Because the community, because if they are not empowered enough in their health, there's no point on start working with them. Right now, before I started working as a medical doctor, I was involved in different NGOs, and I always saw the NGOs as the good guys and the government as the bad guy who was not doing enough. So now that I'm a part of someone who provides services, I see that it's very up to multisectoral collaboration, working between NGOs, the government, donors, and all of us on a common goal, providing people with the right to health. And why I'm saying right, because it is often that we forget that health is our right. And without that in mind, we cannot achieve real like SDGs and all the goals that we want to talk about. And before I finish, I wanted to share something that I learned this week, and that is self-care. I learned that from a different perspective because I knew that from a personal level, but this week I learned it from how to apply self-care into the community level and how that will empower people to actively like try to contribute to their own health and their own development. That's it. Thank you very much, Asha.
So there's a lot more to share, but we're really out of time. There's so much, you know, the whole conference, everyone wants to contribute, and so it's hard to keep to time. I really want to thank the panelists for their observations and for being so patient. There have been a lot of common themes, and I think right from the beginning of the launch, to look at multisectoral action, not just as an aspirational wish list that's always recognized in terms of addressing the social determinants of health, but as something that is a disruptive opportunity to do something, to take a step out of, to work in the health sector, but to take the opportunity to coordinate with other sectors. And some hard lessons that it might take leadership at a different level. And it might need data and learning and that political spark that makes a joint demand that David spoke from the hard realities. When you see the reality of delivering healthcare, you can't avoid the social determinants of health. And that really drives what happened in Jamaica as well, and nutrition. We realized we can only go so far. As the theme said in the morning, if you want to go alone, you know, you won't go far, but if you want to go far, go together. So I want to thank everyone. This is part of the bus that we talked about in the morning, of keeping everyone on board, keeping all the wheels aligned, but keeping right up front the voices and needs of communities and women, children, and adolescents at the heart of why we need multisectoral action and collaboration. Thank you, everyone, for your patience and waiting, and I believe the concurrent sessions that are up and running in all the respective halls. So please welcome us with a final thank you, but also welcome you to head to the concurrent sessions if you can. Thank you.
Thank you, honorable panelists and honorable moderator, for that excellent session. Delegates and esteemed dignitaries, please divert your attention towards the slides. There are important housekeeping information on the slides. Please note that tea and coffee is available outside every hall. It's not just outside this hall, it's outside every hall. So please don't crowd around this area. It gets stuffed logistically. The second thing is that the Wi-Fi is up and running. Please access it. And there are a few hashtags that you can use for tweeting out this event. These hashtags are hashtag EWEC is me and hashtag 2018 PMNCH live. Also, please note that for the following concurrent session that is going to take place in this plenary session, esteemed dignitaries and delegates sitting at the back are requested to please come forward so that it's more logistically it's better and you guys are not that far off. We don't need that much space. Got it. Also, please note that USB kits are now available at the same area where you picked up your conference kits. These USB kits are specially made for all of you. Please pick them up near the atrium. I will announce the list of the concurrent sessions and where they are taking place. Achieving the best start to life through multisectoral action is in plenary hall. Adolescent health, sectors, services, and the path to success is hall 4. Taking multisectoral action work to improve SRHR is hall 1. Taking multisectoral action to work to empower women and girls is hall 5. Addressing determinants of health in humanitarian and fragile settings is hall 2 and 3. catalyzing joint actions to deliver quality care with equity and dignity is Hall 6. Please note that before the concurrent sessions begin, you have a 15-minute tea break. So please proceed towards the refreshments, and then you can move towards these respective halls for the concurrent sessions.